Welcome, fellow learners. Today we're embarking on a really crucial deep dive into a topic that touches nearly a third of the population. We're talking about the neurobiology and, of course, the treatment of anxiety and trauma disorders. We're going to fast-track your understanding by cracking open the core concepts of the circuit-based model.
And our mission today is pretty specific. We're breaking down the brain circuits and the mechanisms of action that, really dictate how all this stuff manifests. We're actually going to bypass the formal diagnostic manuals for a moment and focus instead on the nuts and bolts, the symptoms, where they localize in the brain, and the neurotransmitters that guide our treatment choices.
Which makes sense because we all experience anxiety, right? It's part of the adaptive fight-or-flight response. It's supposed to keep us safe. But the question is, when does that protective mechanism go haywire? When does it become a disorder?
And if you look closely at the clinical picture, you immediately see why just labeling a condition, it's not enough. I mean, there is just an immense symptom overlap. If you contrast anxiety disorders with, say, major depression, okay, the core symptoms are distinct fear and worry versus depressed mood and loss of interest. But they share this crucial group of secondary symptoms, things like chronic sleep disturbance, severe concentration problems, profound fatigue.
And that heightened psychomotor arousal, that feeling of being constantly on edge.
Yeah, exactly.
So that shared profile is key. It raises a huge question. If a patient comes in with sleep trouble, can't concentrate, and is terrified, does it really matter if their diagnosis is GAD or MDD with anxious features? I mean, if the target in the brain is the same.
Precisely. This overlap is what drives the contemporary strategy. It's intensely symptom-based. The human brain, well, it's not organized by the DSM, it's organized by functional circuits. So we deconstruct the patient's experience into a precise list of symptoms, match those to the malfunctioning brain circuits, and then rationally select our treatments.
Okay, let's unpack that. If we look at anxiety phenomenologically, you're saying it really boils down to two core symptoms. You've got fear, that's the panic, the phobia.
The acute response.
And then you have worry, the chronic anxious misery, the what-ifs, the obsessions. What's striking is that these two map onto two distinct yet interconnected biological circuits.
We can start with fear. Fear is anchored by the amygdala-centered circuit. The amygdala, that little almond-shaped structure deep in the brain, it's the central integration hub. It takes in sensory data, it processes context, and it decides very quickly if a threat response is necessary.
So the amygdala is the alarm system. But how does it broadcast that alarm? How does it translate a decision threat detected into that feeling of terror and the physical meltdown that follows?
It communicates outwards through several distinct pathways. So the actual feeling of fear, the affective component, that's regulated by connections between the amygdala and the prefrontal cortex, specifically the orbital frontal cortex and the anterior cingulate cortex. Overactivation there, that's what produces the conscious experience of panic.
And the immediate physical reaction. The urge to run or hide or just freeze on the spot.
That's the motor output. The amygdala talks directly to the periaqueductal gray area, the PEG. And that connection regulates those immediate, desperate motor responses. I mean, if you think about an intense phobia, avoidance is just a motor response. It's the circuitry trying to save you.
But there's so much more going on. We feel sick, our heart pounds.
That's the cascade. The endocrine response is mediated by the amygdala talking to the hypothalamus. That activates the HPA axis, flooding the system with cortisol. And this chronic activation of the stress axis, this is where the physical toll becomes so severe. We see increased rates of coronary artery disease, type 2 diabetes, stroke. It's a huge deal.
Wow. So we're talking about potential permanent physical damage just from chronic, unresolved fear. That is a massive connection. What about that terrifying shortness of breath, the feeling that you're suffocating during a panic attack?
That particular symptom, the respiratory output, is mediated by the amygdala communicating with the parabrachial nucleus, or PBN, in the brainstem. This connection is what leads to that accelerated breathing, that horrible false sense of being smothered.
And finally, the adrenaline surge, the pounding heart.
That is the autonomic overdrive, driven by the amygdala connecting to the locus coeruleus, or LC. The LC is the main source of norepinephrine in the brain. It spikes your heart rate, your blood pressure, and the implication here is pretty sobering.
Okay.
Chronic activation can lead to atherosclerosis, cardiac ischemia, even sudden death. The old phrase, scared to death, well, it might hold some very literal physiological truth.
It's just an incredibly powerful circuit, and it's regulated by this whole mix of chemicals, right? GABA, serotonin, glutamate, norepinephrine.
Absolutely. Now let's pivot to the second major phenotype, worry. This is your apprehensive expectation, the rumination, and this is linked to the cortico-striato-thalamo-cortical feedback loops. the CSTC loops.
The CSTC loop. Okay, that sounds like a network involved in repetitive thoughts, which makes perfect sense for worry and rumination.
That's exactly right. These loops start and end in the dorsolateral prefrontal cortex. And overactivation of this whole feedback loop is the hypothesized generator of that persistent worry. The brain just gets stuck in a feedback spiral.
So what's crucial here is that the anatomy is different. Amygdala for fear, CSTC for worry, but they share the regulating chemistry.
Yes, that's the key. The CSTC circuits are modulated by many of the same neurotransmitters: GABA, serotonin, norepinephrine, glutamate, and also importantly, dopamine. And because they share so many regulators, it gives us a rational blueprint for how to treat them.
Okay, let's move right into those treatments. Let's start with the agents known for that immediate relief, benzodiazepines. If the amygdala relies on GABA, the brain's main brake, how do benzodiazepines boost that braking power?
Well, benzodiazepines act very quickly by enhancing GABA's effects at the postsynaptic GABA receptors. You can think of GABA as tapping the brakes, and benzodiazepines as a chemical foot that just slams down on that brake pedal. They enhance inhibition. And this hypothetically blunts that excessive output from the amygdala, reducing fear, and dials down the CSTC loops, which reduces worry.
That rapid action is why they're so effective for panic, but they're usually just for short-term use. Moving to a different class, what about the alpha-2 delta ligands, like pregabalin and gabapentin? Their mechanism is really specific, isn't it?
It is, and it's important to understand because it's a completely different leverage point. Instead of boosting the brake, these drugs act like traffic cops on the excitatory side. They bind to a specific component, the acyclic subunit of presynaptic voltage-sensitive calcium channels.
So they're acting on the signals before they're even sent out.
Exactly. By binding there, they effectively block the excessive release of excitatory neurotransmitters like glutamate. So they're invaluable alternatives for patients who maybe don't tolerate SSRIs or have concerns about benzodiazepines.
Right. And now we get to the workhorses of long-term anxiety treatment. Serotonergic agents, SSRIs, SNRIs, buspirone. Why is serotonin so perfectly positioned to regulate both fear and worry?
It's a master regulator, really. Its distribution allows it to regulate both circuits at the same time. It innervates the amygdala, and it also innervates every single component of that CSTC loop, the cortex, the striatum, the thalamus. But here's the critical distinction. The therapeutic effects of all these serotonergic agents are delayed. They do not work instantly.
And that delay suggests the benefit isn't just about the chemical being present in the moment.
Correct. It suggests the real effect relies on slower adaptive changes in the brain, things like receptor downregulation or even changes in gene expression. The brain has to slowly adjust to this new level of serotonin.
Okay, let's touch on noradrenergic hyperactivity, the system driven by the locus coeruleus. Excessive NE output drives those peripheral symptoms, the pounding heart, sweating, the nightmares.
Yeah, and pharmacologically, the system can be a little confusing to target. If you use a norepinephrine reuptake inhibitor, you initially boost NE activity, which can actually make the anxiety transiently worse. That's why patients sometimes say they feel worse before they feel better. But that sustained action causes the postsynaptic receptors, like the VO1 receptors, to downregulate over weeks. And that leads to the eventual delayed reduction in symptoms.
You have to wait for the brain to kind of build up a resistance to its own overactive signal. But some drugs target those physical symptoms more directly, right?
They do. Alpha-1 adrenergic blockers, like prazosin, are used very effectively to reduce the central symptoms of any overdrive, especially the vivid nightmares you see in trauma disorders.
So what we've discussed so far is mainly about suppression using drugs to put a lid on an overactive circuit. But the core fear memory, the learning, it's still there. This leads us to the most innovative, really future-focused approaches. Strategies designed not just to suppress fear, but to actively unlearn it.
Right, and to do that, you have to understand the difference between fear conditioning and fear extinction. Conditioning is the learning of the fear, the traumatic memory itself. It uses glutamatergic synapses in the amygdala, triggers NMDA receptors, and a process called long-term potentiation, or LTP.
And LTP is basically permanent learning, isn't it? It carves a super efficient highway into the circuit so that fear response is just indifferent.
Precisely. Now, fear extinction, on the other hand, is not forgetting. It is active new learning. The ventromedial prefrontal cortex and the hippocampus learn a new, safer context. This new learning then activates inhibitory GABA interneurons inside the amygdala to suppress the original fear response. It's like building an inhibitory gate.
But, as anyone who has been through exposure therapy knows, that extinction can be really fragile. The original fear is still under there, waiting.
That's the challenge. Extinction is labile. If the context changes, the conditioned fear can just pop right back up. We call that renewal.
Which brings us to this novel therapeutic idea,
Yeah,
using drugs to actually strengthen that new extinction synapse.
exactly. The idea is to combine exposure psychotherapy with agents that boost synaptic plasticity right at the moment the patient is learning this new safe context. So, for example, pharmacologically boosting NMDA receptor activation at the time of therapy could increase LTP, tipping the balance toward the extinction pathway and maybe making that inhibitory gate permanent.
That's amazing. That's about making the new memory stick. But there's another approach that deals with the old memory, right? Disrupting its consolidation and reconsolidation.
Right. Consolidation is the process of forming the memory in the first place. Some agents, like beta blockers, if given right after a trauma, might mitigate the formation of that memory. But what is absolutely game-changing is the concept of reconsolidation.
What's the insight there?
The insight is that when a consolidated fear memory is actively retrieved, when you talk about it in therapy, it briefly becomes labile again. It becomes changeable. It requires new protein synthesis to lock back down into permanent storage. So the goal is to block that reconsolidation process while the memory is active.
So if you retrieve the emotional memory during therapy, and then you block the protein synthesis,
Mhm.
you could potentially remove the emotional charge forever.
We might. This is why researchers are testing combinations of psychotherapy and agents like beta blockers or even psychoactive agents like psilocybin, MDMA, and ketamine given during therapy sessions. The goal is to open that window, disrupt the memory, and prevent it from locking back down with its emotional punch intact.
That is a truly remarkable pivot in strategy.
Okay.
Okay, let's quickly summarize how these principles apply to specific anxiety subtypes.
For generalized anxiety disorder, or GAD, which is mainly chronic worry, we have the widest array of options: SSRIs, SNRIs, buspirone, thiazolidines. Benzodiazepines are useful for symptom surges, but you have to be very cautious, especially in patients with a history of substance abuse.
And for panic disorder, that acute catastrophic fear, the treatments overlap. But there's a clinical detail here about MAOIs, right?
Yes, a historically neglected class of antidepressants, the MAOIs, have powerful efficacy for treatment-resistant panic, and they have to be considered when other agents fail.
Okay, what about social anxiety disorder?
For SAND, SSRIs and antiligans are effective for the chronic worry. But what's unique here is the utility of beta blockers for performance anxiety. They don't touch the worry circuit, but they block the peripheral physical symptoms, the sweating, the pounding heart, which can be enough to get someone through the feared situation.
And finally, PTSD.
For PTSD, our psychopharmacological treatments are generally less effective for the core symptoms. They often target comorbidities like depression and insomnia. And benzodiazepines, specifically, are used with great caution. There's limited evidence for them and a very high substance abuse risk in this population.
But there is one standout agent for PTSD.
Prazosin, the II-1 antagonist. It specifically targets and prevents the nightmares and hyperarousal, which really distinguishes it from other anxiety treatments.
So to wrap up, we've established that anxiety disorders are anchored by fear, driven by the amygdala, and worry, driven by these CSTC loops. They're all modulated by serotonin, NE, GABA, and glutamate. But the biggest takeaway here seems to be that treatment is evolving beyond simple suppression and moving toward actively engaging the brain's own capacity to learn and unlearn.
Absolutely. If we connect this to the bigger picture, what really matters is the malfunctioning mechanism. Whether you have persistent GAD, intermittent panic, or conditioned PTSD, understanding the underlying fear and worry circuits is the only path to rational treatment selection.
You know, the most profound shift in this field, I think, is the idea that psychotherapy and psychopharmacology are synergistic. Could we be moving toward a future where drugs aren't just taken daily to manage symptoms, but are precisely timed to a therapy session? Pharmacologically opening a window where the brain can actively overwrite traumatic memories, maybe for a permanent cure? That's a powerful and hopeful thought to take with you.